Pyosalpinx or infected endometrioma. We shall see the value of collaboration between the surgeon and the pathologist in unraveling this dilemma. This case was that of a 30-year-old Nolipara who was a student, presented with suprapubic pain, weakness, fever, prolonged menses, dizziness, and nausea. The pain and weakness started a month prior to presentation, while the prolonged menses lasted for 12 days. She was admitted earlier on and had blood transfusion. A general examination revealed an acutely ill-looking young lady, while the abdominal examination revealed a tender mass, which is equivalent to 22 weeks of gestation. The viral screen, renal and liver function tests were all within normal limits. Her PAX volume was 29, while the WBC was 11. Blood film showed dimorphic anemia and left shift of neutrophils with toxic granulation. The ultrasound differentials were pelvic abscess to rule out infected endometrioma. She had exploratory laparotomy, and the findings were that of infected bilateral endometriotic cysts with dense adhesions. Both cysts were buried in adhesions. The cysts ruptured, and the contents were chocolate-like and mixed with purulent material. The ovaries were not seen separately. The left tube was edematous, while the right tube was not seen. So now let's look at the still transabdominal ultrasound images of this case. Note the shape. Generally, on longitudinal section, the tube appears pear-shaped. As you can see, this is pear-shaped. Of course, it could also be ovoid or retort shape. The content in Pyosalpinx, usually low level, echoes. The septation is usually incomplete, as seen in this case. And on transverse section, in acute inflammation, as in this case, one can see this thickened wall and the thickened endosalpingeal folds that gives this cockwheel appearance. Here you can see the ovarian tissue with a complete septation. The wall is often thick, greater than 5 millimeters, as can be seen here. And the vascularity is usually high. This is not the vascularity one expects in the case of Pyosalpinx. One expects something much more than this, but not the vascularity here of 2 to 3. Here one can see that there was ovarian involvement. This appears to be the thickened wall of the tube. This thickened endosalpingeal fold, but this looks like part of the ovary. So this is more like a tube ovarian complex, because both the ovary and the tubes can be clearly distinguished, unlike a tube ovarian abscess, where the tube cannot be distinguished from the ovary. Now this patient has exploratory laparotomy, and this were the right and the left cysts. But as I alluded to earlier, there was dense adhesions, and the ovaries were not identified separately. So note the findings from the histopathologist. Microscopy A received an open cyst because the cyst ruptured in the course of surgery. Open cyst measuring so. Further opening reveals a multilocal cyst with rough inner lining. B revealed a cyst measuring so. Opening revealed a multilocal cyst containing purulent material. and look at the microscopic findings. And diagnosis was bilateral Pyosalpinx. So because I was at the surgery, and I knew that we couldn't see the both ovaries, but we could clearly see the left tube. So when I saw this report of bilateral Pyosalpinx, I was a little bit confused. So I had this discuss with the pathologist that, well, this was my ultrasound scan suspicion. These were the findings at surgery, which is not in keeping with the report of bilateral Pyosalpinx. So he went back and had a second look. And what did he find? He found this, and this was his report, that siderophagy is suggestive of all hemorrhage, giving a chocolate-colored appearance. In this section, he found an island of endometrial gland within a fibrocollagenous stroma. And here in B, he found fibrocollagenous wall infiltrated by polymorphs and covered by micro abscesses. So the conclusion: A was endometriosis with abscess, and B, acute suppurative inflammation. Now, if you look at this ultrasound still image, you can see that this looks like the tube, and this part here looks more like part of the ovarian tissue, and of course, this is ovarian tissue. So one can see how collaboration with the pathologist can unravel so many challenges. So it's not enough to receive the report of the pathologist and then complain that it's not consistent with either the clinical or the surgical findings. It's important to discuss with the pathologist. When that is done, issues can be cleared, as was done uh, in this patient. So our take-home message is that open communication with the pathologist will help improve the quality of care of our patients. Thank you very much for listening.